So this was a 62 years old male presented with a CAD NSTEMI, and you can see there is a separate origin of L6 and LED. This is a caudal view with the right radial root. So in this view we can see there is a sort of LED, and this catheter was Tiger catheter with right radial root. So to engage the LED we have to change the catheter. So we changed to a JL catheter, and this is the directly we engage the LED, and you can see there is a lesion in the osteoprox LED. This is a separate origin of LED. You don't see here the LCX, and there was no left main at all. So we decided to do this angioplasty to osteoprox LED. This is the 80% stenosis. Patient had presented with the chest pain and NSTEMI. The top tube was highly raised in this patient. So we decided to do the, as it is osteal lesion, we decided to do the imaging. So we ordered IVUS. So this was the second day, and we ordered the IVUS, and for the IVUS catheter and all, we took a femoral axis, and this is the thing on the femoral axis. This is a RO view, and you can see how tortuous is the femoral. So this was the wire. And then we decided to take on the left side femoral axis, but on left side also this is the picture, tortuous with artery. So we decided to go with the radial. So in radial also there was a luxuria. It was a very difficult and complicated case. You can see the passing of the wire, but somehow we managed to pass the wire in the radial. And then we took a shot, and we don't know how much distance is there from the in between origin of LED and LCX. So now we selectively engaged to LED. There's a selective engagement of LED, and now we wanted to see where is the lesion right from the ostium and all. So whether there is a short LM or not, that is that we wanted to see. So we did the IVUS for this. So this was IVUS catheter pullback. Then we wanted to take we wanted to see the whether there is a any left main is there, or directly the LED has origined directly from aorta. So this is the shoot when IVUS catheter was in. So there was no left main at all. So on IVUS we just got the area in the tightest portion is the 3 mm square in the proximal LED. So at least we want 7 to 8 to 9 mm square area, and there was a no LM. And in ostial LED there was a mild plaque. From IVUS we got then again slightly we disengaged, and this is the wire, BMW PTCA wire with right radial root. With this is a JL catheter, JL3. Then from IVUS understanding we took a stent of 3.5 into 28, and we wanted to deploy it from the ostium because there was a lesion in the ostium also. Ostial LED. This is a difficult coronary anomaly, and right from the below of origin of LED there was a L6 origin. So we wanted to save L6 also. So we took a stent, and we started to deploy it from the ostium of the LED, and we planned to flare it in the aorta. So this was the placement of the stent right from the ostium of this anomalous LED origin. This was not a straightforward origin of the LED. In the later stage, after deployment of stent and took a stent boost, then I'll show you the origin of this LED, how anomalous it was. Now we wanted to keep 1 or 2 struts in the aorta, and so this is the stent placement. This is a caudal view, and we deployed this stent at the 12 atmospheric pressure, and this is the picture. So stent is well expanded from this angiographic view, and 1 or 2 struts in the aorta. So we wanted to flare that. Then we took IVUS shot again to see the stent deployment, any under expansion or not. So this was a picture, and from angiographic view, you can see there is a area achieved is at around 8 to 9 mm square. So this is a cranial view, and you can see how wonderful this osteoprox LED has opened up. And then again we took a shoot of IVUS. This IVUS pullback after the stent. So there was some sort of under deployment, so we took a NC balloon of 4 and we did the NC right from distal to proximal. So this was a NC with 4 balloon with stent boost guidance. We did this NC, and now with this boost you can see the what is the origin of LED and how it was. So in this scene you can see the flaring of this stent we have done in the aorta, and you can see the how anomalous and different origin of LED. That is why there was a problem in the engagement, and just below there's a LCX origin, and this was a picture after the stent deployment and NC. You can see how wonderful that osteoprox LED has opened. There's a caudal view and the catheter in the aorta to see the LCX also. You can see the osteoprox LED. The area we achieved is 9.5 mm square. This is after NC, you can see. So this was a very difficult anomalous origin of LED, in that to a separate origin, and just below that origin is anomalous, and below just that origin there was a LCX, and there's a lesion right from the ostium to the proximal LED. So this was a complex PTCA to separate origin LED, which was anomalous origin, and then patient was shifted to ICU. Patient was stable.